Welcome to our monthly IBD GECCO meeting, which is of course hosted by the GI Foundation in association with Project ECCO, the University of New Mexico. These GECCO sessions are of course held every single week, and our next one, next Wednesday, will be on hepatocellular carcinoma. So please post any questions that you have on the chat. Today we have 72 registrations from 14 different countries. The majority of these are in sub-Saharan Africa, but today we also have 2 delegates from Saudi Arabia, so welcome. So the theme of today's GECCO meeting is IBD and malignancy, and we're going to have our 2 speakers, Professor Mashiko Setshedi and Dr. Innocent Francis. So Innocent is going to start off with an interesting case that we have recently managed. So Innocent, can you start sharing your screen, please?
Sure. Just a minute, I'm just... So I'm just trying to share it now. Okay. Sorry. Shared it before. Shall I want to share from there? Because I seem not to be seeing it clearly from here again.
Cheryl, will you be able to share?
Yeah, I think she can. Cheryl?
Give me a moment.
Okay. Now we shared it before. It's not to be picking up again. Okay, here I go. I think I've seen it now. All right, can you see it?
Yeah, now you just need to put it onto slideshow.
All right. All right, thanks so much. Once again, thank you so much for the opportunity for presenting this interesting case. Say sometimes in life you are confronted with some challenges that you are in between just 2 opinions. Either you are going to run away from it, or you are going to face headlong and confront it. And this is one of those cases that you have to decide which way to go. So when my fears came knocking at my door, what do I do? And in case of breast cancer and Crohn's disease, a balanced act. So I'll be presenting Mrs. MV, 51-year-old female diagnosed with ileocolonic Crohn's disease in 2000. She was initially seen and managed at Carprima Hospital and Tigerberg up till 2007. During the course of her management, she reported having multiple perennial INDs during the course of her management. She was transferred to Grotius Care Hospital in 2007, during which she had a bone mineral density scan done that was normal. She also had examination under anesthesia and contrast enema, upon which she was assessed with perianal disease complicated by fistula in ano, rectovaginal fistula, and strictures as well. She was managed initially with immunomodulators, azathioprine and mesalamine. She defaulted in between and recommenced again because of the treatment. And in March 2010, she had a defunctioning stoma. Then in August 2012, she was commenced on the biologic adalimumab with methotrexate. We have to drop the AZA because she had a poor response to it, coupled with the fact that she had defaulted it a couple of times before this time. Other concerns with her were the fact that she also had a smoking history. She also had hepatitis B core IgG positive with undetectable viral load, as well with iron deficiency anemia. And in 2015, she had a colonoscopy via the stoma. On the proximal, from the proximal part of it, it was all normal up to the TI. On the distal limb, she had mucosal slough with strictures at about 15 cm. And histologically, she had features that are in keeping with diversion colitis. Then the same 2015, in December, she was then diagnosed with cervical myeloradiculopathy with MRIs showing a massive loose central disc herniation at C6, C7. And subsequently, she underwent C6, C7 fusion surgery. That was successful. And then in 2019, while still on Humira with methotrexate, we noticed a left breast mass. She went ahead to have a biopsy done that showed fibroadipose tissue as well as fragments that were without remarkable assessment overall. No breast duct was seen, no lobes present as well. So therefore, it was deemed as suboptimal for diagnosis. Unfortunately, 2019, we all know that globally it was a very critical period, mostly from December onward. That was just about the outbreak of COVID-19. So therefore, between that 2019 December up till in 2021, there was a huge gap in between. But prior to that time, she also had a mammogram done as well, December 2019, that showed heterogeneous dense fibrogranular tissue. And based on category, she had a breast BRAF2, which is more or less a benign pathology. And then on the left side is BRAF0, which is incomplete study. And she was also booked for an ultrasound scan by the breast clinic, but unfortunately, she missed the appointment. But from the IBD point of view, she remained in remission on Humira and methotrexate. Again, because of the COVID-19, it was all quiescent until in 2021, this February. She had another biopsy again that showed fragment of adipose tissues with scanty free-line atypical glandular cells, but negative immunohistochemistry. Again, the tissue that was provided was insufficient. Therefore, a biopsy was also strongly suggested as well. And then the following month, which is March 2019, she had a repeat biopsy of the left breast. And the mass was located at about 9 o'clock position. And this time it now showed invasive carcinoma of the left breast with no special type. This is against the background of already existing Crohn's disease, and then also with the spinal pathology that she went surgery for. So she now, she then underwent a left quadrantectomy and sentinel lymph node also biopsy as well that turned to become positive. And it was indeed a high grade one, it was invasive one. So she had a grading of 7 out of 9 with lymphovascular invasion. So the summary of this is that here we have a 51-year-old lady diagnosed with stricturing, physiologizing, and perennial Crohn's disease for the past 11 years with background smoking history and also iron deficiency anemia, and also Hep B core IgG positive with undetectable viral load, with a previous C6, C7 fusion surgery, and she had multiple perianal IMDs and a defunctioning stoma. Previously managed with AZA and mesalamine and later changed to Humira and methotrexate, who went into remission, but now diagnosed with invasive left breast carcinoma. So the question is, now we are stuck. What next in the management of Crohn's disease? I think at this point, I want to hand over to Prof. Mashiko for her to continue.
Thanks, Francis, for that clinical case. So before we discuss the actual case, we thought it would be important just to go over, this topic of malignancies in IBD. So this is a broad topic, and my disclaimer is that this is not going to be an overwhelming, comprehensive review of the subject matter, because that's not possible. And I think people can, go to the resources to read for themselves. It's quite a big topic. What I've tried to do is just to pick out the important points that will hopefully induce a discussion around what patients do, what all of us do when we're faced with patients like this, and also just some snippets which are a little bit more relevant to this particular patient that we're presenting. So ECCO did come up with guidelines on inflammatory bowel disease and malignancy. These were published in 2015, so they are a little bit old. And if you actually read the guidelines, some of the controversies have now been resolved with more recent data. So if you just want something sort of as a good baseline from which to start your reading on this topic, I would suggest those ECCO guidelines. And then a more recent review paper published by the Swiss group. So the Swiss Society of Gastroenterology gives a bit more updated data on some of the risk factors of the malignancies, particularly those associated with the therapies that we use. And then there's other stuff, but I thought I would just highlight these two references. As we know, the prevalence of IBD overall is increasing, particularly in newly industrialized countries and in developing nations. We know that data is out, it's established, but also because of the way we are managing patients and the armamentarium of the drugs that we have, the surveillance programs that we have, the new drugs that are coming up, our management of the condition has improved significantly. So as a result, you have more patients who are elderly, who are IBD patients who are elderly that you see. So the prevalence of elderly IBD patients is increasing. And this is aside from the bimodal distribution of IBD as we know it. And also it's important to note that in terms of cancer, so after cardiovascular disease, cancer is the second leading cause of death worldwide. And it is estimated that 1 out of every 2 individuals will suffer one cancer during their lifetime. So that is also common. We also know, and this is established, that IBD is a risk factor for cancer, and I'll get into the mechanisms for that in a while. And so it's not surprising that we are faced increasingly with elderly patients or even younger patients with IBD who also have cancer, either as a new diagnosis or as presenting with a previous history of cancer. And this indeed does make the management of these patients quite complex. And I think Francis' case has very nicely captured that. So just to make sure that Francis and I are not talking to each other, may I ask you to participate in a poll? And the question is very simple. Based on your reading and your knowledge, what would you say the incidence of IBD-related cancer is? Do you think it's increasing worldwide, decreasing? Maybe it is, maybe it isn't, you're not quite sure. So this is an all opportunities poll. You really can't get the answer wrong. So I do encourage your participation. I'll just give it a few more minutes. We started with 100% of people saying yes. And now some people are becoming a little bit unsure. I like 10% of the people are sitting on the fence are saying maybe. Those are my kind of people, hedging your bets. Cheryl, it's okay. I think we'll stop the poll. So 85% are saying that it is on the increase, and 10% are non-committal, and 5% are saying no. So as I said, this is an equal opportunities poll. All the answers are correct. So the overall incidence of IBD-related cancer is actually not increasing. However, if you substratify the cancer, so if you look at lymphoma as well as the biliary tract cancer, so PSC, etc., those cancers are increasing. And if you compare a decade ago to now, the incidence of cancer worldwide is actually a little bit less than it used to be, but it is still high compared to the general population. So all those answers are in fact correct. It just depends on whether you're looking at overall cancer or specific cancers. The reality of the matter is that patients with the IBD are at increased risk of cancer, compared to the general population, and some cancers are higher than you would expect. So what does the data say? So the mechanisms of cancer. So cancer in IBD, we all know it, and the mechanisms are twofold. So we have cancers that are related to inflammation. We all know the inflammation cancer sequence, and then cancers that are related to immunosuppression. So if you look at cancers that are related to inflammation, all the ones that are listed there are very well known to us. So colorectal cancer, we know it. We know the risk factors for colorectal cancer in patients with IBD, as well as Crohn's colitis, extent of disease, the number of years of disease, etc. In Crohn's disease, if the colitis involves about 50% of the colon, then that is an increased risk of developing colorectal cancer. The pooled incidence is about 2, slightly higher in ulcerative colitis because of the extent of the disease compared to Crohn's. Small bowel cancer, we know, is very, very high. It's 27 times the risk in patients with Crohn's disease involving the small bowel. Small bowel cancer as an entity is quite rare, but in these patients, the risk goes up 27 times compared to the general population. Intestinal lymphoma, the risk is 3-fold higher compared to the general population. I've highlighted anal carcinoma. This is something that we don't talk about a lot, but in patients with chronic fistulizing perianal disease, the risk of cancer increases. And you need to be aware of this, particularly in patients who develop new symptoms. So new perianal pain, new discharge. Every time when the patient is having an IND or any sort of investigation, one should biopsy for cancer. These cancers, compared to your typical cancers, for instance, those that you might see in men having sex with men, are not related to HPV. The prognosis is much worse. And you may have both squamous as well as adenocarcinoma of the fistulae and the fistula tract. So this is something to really highlight and something to look for, which we don't often do. We're always looking for sepsis, etc., but I think we forget to look for anal carcinoma. And then we all know the risk of cholangiocarcinoma in patients with IBD. The risk is as high as 6-fold compared to the general population. But when you have IBD, it goes up as high as 160-fold. And we know the risk factors for these, which have influenced the screening guidelines. If you go to the left-hand side of the picture, if you're looking at the cancers associated with immunosuppression, I think thiopurines, we all know very well in terms of the risks associated with the non-melanomatous skin cancers, as well as lymphoma. This lymphoma may be EBV or non-EBV related, and we know that the risk factor for this is typically young men who may then develop a very, very aggressive hepatosplenic cancer, lymphoma. And then in Crohn's disease, the risk of lymphoma is higher than it is in ulcerative colitis. And then in both conditions, patients may present with acute myeloid leukemia as well as MDS, so myelodysplastic syndrome, and then urinary tract cancer and cervical cancer, particularly in patients with fistulous disease, has been reported with the use of thiopurines. So it's important to understand that the mechanism may be related to the inflammation itself, and that typically follows the molecular sequence as it does in sporadic cancer. So you have mutations in the TP53, and then the later mutations in the APC gene. So that is in patients with inflammation-related cancers. The patients with immune suppression-related cancer, the mechanism is slightly different than we find in inflammation-related cancer. There is an overlap with patients who've got EBV-associated lymphomas, where the inducing agent is the EBV through the inflammation sequence, and then the addition of thiopurine therapy with or without anti-TNFs can promote, as I say, aggressive lymphoma. So this brings us to the second poll question, and it says, of the cancers related to immunosuppression therapy, which one of the following is associated with anti-TNF use? So we know the risks with thiopurine use quite a lot. There's been a fair amount published with that, but what is the risk with the anti-TNFs? There is only one correct answer here. So nobody's going for cervix cancer. there's a bit of a tug between melanoma and the non-melanomatous skin cancers and breast. I think our case presentation influenced the responses here. Nobody's going for none of the above. Okay, Cheryl, I think it's okay to end the poll. And the answer will be revealed in the next slide. Thank you. All right, I'm just trying to stop. Right, okay. So if you look at the malignancies that are linked to IBD therapy. So if you look at the left-hand side, we are all very aware of the thiopurines. There's a thiopurine 6MP in relation to the non-melanomatous skin cancer, in relation to intestinal lymphoma, and even, as I say, EBV-induced and even non-EBV-induced post-transplant lymphoma and post-infectious mononucleosis lymphoma. And the risk is 4 times in patients that are on thiopurines compared to those that are not on thiopurines. The most recent data in terms of cervical cancer is conflicting, but it's leaning towards no increased risk with thiopurine. So if you look at the ECCO guidelines, they suggest that there is an increased risk, but the more recent data suggests that actually the risk is not as high as was initially thought. And then in terms of urinary tract cancers, so these include renal cell carcinoma, etc. There is one study which wasn't really powered to answer specifically this question, but it suggests that there is a 2.5-fold increased risk of urinary tract cancers in patients that are on thiopurines. But I think it's safe to say that the non-melanoma skin cancers, we know this is an established risk factor. This is something that we should be advising our patients about in terms of prevention, in terms of sunscreen, staying out of the sun, sun hats, etc. The only cancer that seems to be associated definitively with the use of anti-TNFs is melanoma. And the risk is quoted here to be about 1.2 to about 4 times compared to patients who are not on anti-TNF therapies. Otherwise, in general, and more recent data repeatedly is supporting the notion that anti-TNFs are generally safe apart from the risk of melanoma. A lot of the studies in the past are from patients in the rheumatoid world, so RA, psoriasis, and not much data has been done in patients with IBD. But in all of these studies, the data suggests that methotrexate is safe. There is really no risk associated with cancers, and neither is there any risk with the cyclosporin. The cyclosporin mainly because in our setting, we tend to use it for shorter periods of time compared, say, to patients where it's been used for rheumatological conditions. So just to summarize, in general terms, anti-TNFs seem to be safe apart from melanoma, thiopurines for non-melanoma skin cancer, and overall increased risk of cancers compared to the general population. And then it looks like urinary tract cancers are signaling in patients that are on thiopurine use. This study has been done by our friend Silvio Danisi, as well as his compatriot Laurent. It was published in the Journal of Crohn's and Colitis recently. I think this is February 2021. And here what they've done is that they looked at a systematic review of the risk of anti-TNFs with malignancy in patients with IBD. And basically they were able to evaluate 28 studies. Most of them were observational studies, but the cohort was just over 300,000 IBD patients. So this is quite a large group of patients, followed up for a reasonable amount of time, up to 80 months. And in this entire cohort, only 1% of patients developed a de novo cancer. Most of the cancers were non-melanoma skin cancer, 18%, and then digestive cancer. So that includes PSC, intestinal lymphoma, liver cancers, etc., and then hematological malignancy. So that includes leukemias as well as lymphoma. In this cohort, the percentage of patients with breast cancer was 5%. But overall, the study comparing this cohort of patients to normal population and adjusting for underlying populations found essentially that there was no increased risk of cancer in patients that are on anti-TNF therapies, which I think is quite comforting. And as I say, this is late data, which is consistent with more recent data suggesting that the risk is really, really low. So the question really is then, what do you do in a situation like the one we faced, where you're managing a patient with quite aggressive phenotype of IBD, who is on a combination therapy, but has now developed a new cancer. So this is the final poll question. We were faced with this dilemma, what do you do? So the question is really, prior to chemotherapy, are you concerned at all about the medications that she's on? So do you stop both drugs? Do you continue both drugs? Do you stop the one but not the other? Do you put your hands up in the air in despair and call a friend? So I like call a friend. I think you should call a friend anyway, even if you think you know what you're doing. Nobody's going for stopping both drugs. So the majority, so a third are going for stopping the methotrexate, but not the biologic. Sorry, continue the methotrexate, but stop the biologic. So there seems to be concern about the biologic. And just 1 in 5 is concerned about the methotrexate. So there is concern about both these drugs. All right, Cheryl, I think it's okay. I think the ensuing slides will hopefully share some light as to what one should consider doing. So I'm going to go ahead and hopefully, as I say, the slides will answer that. So in terms of how one should manage the medical therapy for IBD in patients with either a history of cancer or a new diagnosis of cancer, as in our patient, or a patient who's had cancer before and is now presenting with recurrent and neoplastic disease. It's notable that these tumors, so the second tumors, account for 18% of incident cancers in the USA, and they are more common than first cancers. So this is a problem. It's a real issue, and it needs to be managed seriously. And I think it's also important to note that recurrent cancers are not always caused by the cytotoxic therapy of the first tumor. They may simply reflect a persistence of risk factors, either patient factors, lifestyle factors, host factors, genetic predisposition. I mean, this patient has been smoking, had laryngeal cancer, now has breast cancer. So clearly smoking as a risk factor needs to be addressed. In her, there's also the concern of her hepatitis B viral status. But in any event, I think this case shows very, very elegantly why you need MDT co-management of these patients, because there are many things that need to be taken into account. So obviously the individual case, the activity of the IBD, which is really turned out to be quite important in our decision-making with this patient, the concomitant therapy, this patient was on combined therapy with a biologic and an immunomodulator, her age, of course, the type and the stage of cancer. So all these things are considerations in how you finally manage the patient. So the recommendations from ECCO, which is from that 2015 paper, is that in patients with active IBD with a history of malignancy, it is safe to continue 5-SAA, nutritional therapies that may apply, corticosteroids, topical therapy where possible. These can be safely used. They do also say quite clearly and categorically that in general, if you can avoid thiopurines, calcineurin inhibitors, and anti-TNF agents, these should be stopped at least until the cancer therapy is completed. But of course, you know, patients are not textbook cases, as was the case in this patient. So having said that statement about avoiding these agents where possible, they do concede that in patients who've got severe flares that do not respond, you know, to the steroids and the nutritional therapies and 5-SA therapy, the use of anti-TNFs, methotrexate, should be considered on a case-by-case basis. So I think what these recommendations are saying that in patients that are a little bit more complex, where their disease is a little bit more nuanced, you need MDT, and you need to assess each case on its individual merit. It's not possible to make broad streaks of recommendations for these sorts of patients. They go on further to say that data from registries including the SEER program, suggest that individuals who survive cancer are 14% more likely to develop a second malignancy than those in the general population. So it becomes more important about how you manage this patient now in terms of their longevity and their future potential recurrence of the cancer. So these are big decisions, I think, that need to be made when you're dealing with patients like this. And they also say that based on the data in transplant patients, physicians should, so where you are able to stop the therapy and the case is not as complicated, they do suggest that you stop therapy for at least 2 years to a maximum of 5 years. And the reason for this is that the data has shown that the recurrence of cancer seems to occur at higher levels in the first 2 years and then wanes off towards year 5. Hence, they suggest this 2 to 5 year hiatus where possible. And they say other things that need to be considered. Apart from the fear of a potential recurrence, is that you need to consider the risk posed by each immunosuppressive agent drug that you're using in the setting of the specific cancer history of the patient, and also the amount of time that has passed since completion of the cancer therapies. Those are the factors that need to be considered for each patient. So what is the recurrence rate of cancers in patients who are on these IBD therapies? Well, it is classified according to low, intermediate, and high. So low being recurrence of less than 10%. And you can see that incidental asymptomatic renal cell carcinoma falls in there, lymphoma, cervix, and thyroid. Breast cancer falls in the intermediate risk band. So that risk of about 11 to 25%. So it's a median of 20% for the risk of recurrence of breast cancer with ongoing therapy. And this is quite significant. And then there are those cancers where the risk is really high, higher than 25%. And here you're looking at symptomatic renal cell carcinoma, the skin cancers, bladder cancer, and myeloma. So our patient fell into this 20% risk of recurrence with her therapy if we were to continue. This slide basically confirms what I've said earlier, that if you have these cancers here on the left-hand side, you're generally going to try and avoid thiopurines because we've shown that they seem to be the culprit in most of the cancers, lymphoma, the AML, the non-melanoma skin cancer. And then you're generally going to try and avoid anti-TNFs in patients who've got melanoma, and drugs that are relatively safe that you can default to, at least initially, would be things like methotrexate and then steroids and the 5-SAA compounds. So it does really depend on what cancer the patient is presenting with and what medication they've been on and its likelihood of promoting a carcinogenic state. So when I was reading these guidelines, I could sense how the authors were struggling really to come out with a very clear, very categorical guideline, because I think this is not an easy space and the patients, as I said, are not easy. So having said all of that, that you should avoid anti-TNFs, you should avoid immunomodulator therapy if you can, having considered all the factors. This is their parting shot for this part of the talk, that anecdotal data, however, suggests that cautious resumption of thiopurines or anti-TNF therapy when needed can be attempted as early as 3 months after cessation of chemotherapy. So it gives you a window for those patients that are really difficult to treat, where you cannot afford to wait for 2 to 5 years before you recommence therapy, that you can use this cautiously. And I think, as I say, within the context of an MDT discussion, together with patient, the patient needs to understand all the risks that are involved and all the potential complications. Because it has been shown from really poorly powered studies, which in my view really don't say anything, but that patients with metastatic disease, the cancer progression is not dramatically accelerated by anti-TNF agents. And I think this is true because the early signals suggest that anti-TNFs are going to be safe, but clearly more studies that are adequately powered need to be done. At the end of the day, it's about improving the patient's quality of life. And they say that when this is a priority, then all of these guidelines that they give are outweighed by the patient's quality of life. And that means that if the patient requires the anti-TNF therapy, and so that should be it. So that was the first question about what you do about the medical therapies. The second question to address is, what effects do the medical therapies of IBD have on the progression or recurrence of cancer? And quite simply, the good news is that they don't. My slides are going to be up on the Gastro Foundation website. So there's no obvious excess risk of developing a second cancer while patient is being treated with anti-TNF therapy. Again, speaking to the safety signal of the anti-TNFs. And then the last question really is, what are the effects of these treatments that are used for cancer now? What do they have on the course of the IBD treatment itself? And again, the data is limited. And there are some studies that suggest that some hormonal therapies for prostate or breast cancer can activate the immune system and so may cause worsening of IBD. In the same vein, however, some properties, some immunosuppressant properties of the anti-cancer therapy may actually be good for the IBD and may induce remission. So it's sort of a balanced act, and I guess it depends on host factors, it depends on the drug properties, and so it is an unclear area. So this area remains unknown. So these are from the guidelines, but I found a recent paper that was published in Clinical Gastroenterology in April 2020. It is a retrospective study, so obviously we would need more observational cohort studies, but here they looked at about 450 patients with IBD. 78% had breast cancer, the remainder had prostate cancer, and 90% of these patients had inactive IBD at the time of cancer diagnosis, and of these, about a third relapsed. And the hazard ratio for relapse, whether with the immunomodulators or biologics, was about 2. So these patients were 2 times more likely, if they were on immunomodulators or biologics, who had been previously inactive at the time of cancer diagnosis, they do relapse. So the risk of our patient who was in remission when her cancer diagnosis was made of relapsing is about a third, 30%, which given her severe phenotype of disease is not insignificant. And the risk of relapse was associated with hormone therapy, again with a hazard ratio of 2. So what about IBD and breast cancer? So all the data that I've shown you speaks to the lymphoma, the skin cancers, etc. But really there's no data that I could find specifically on liver cancer, very little data on lung cancer, and even less so on breast cancer. And in this recent paper, which was published in 2021, here they looked at inflammatory bowel disease and the risk of breast cancer. This was a meta-analysis of cohort studies. And basically they showed that the pooled odds ratio was less than 1. So there was no significant influence on breast cancer risk. And this was regardless of whether you had Crohn's disease or ulcerative colitis, and even irrespective of your geographical area, because there was a suggestion that patients in certain areas of the world like Asia, etc., might be more likely to have cancer compared to European counterparts, but this was not borne out in the study. So this again may be a signal that breast cancer in this population is not as high on the list as the other cancers that we're well familiar with, whether they're due to inflammation or the effects of therapy. I added this in because we did a little study here, which was published in 2019 in the SMJ, where we looked at our cohort of patients with IBD, and on most of them on immunosuppressant agents and the risk of cancer. And basically we found 4.8% of incident cancers, and most of them were non-melanoma skin cancer, but breast cancer featured quite highly in this cohort, and colorectal cancer, not surprisingly, and then melanoma 10%. Obviously, this data was not corrected for the underlying population risk of breast cancer in the Western Cape. But I wonder if somebody, on the call knows what the prevalence of cancer in South Africa is, and whether this number is inflated or whether it's more or less reflects the underlying population risk. So just briefly to conclude, I hope I've shown you that IBD per se, we know, is a risk factor for an increased risk of malignancy based on the inflammation cascade, but also that some therapies also have increased risk, as I've shown you. And I think what really this represents is what is called the vulnerable equilibrium, where too much immunosuppression can predispose a patient to cancer, whereas reducing inflammation is also beneficial, has a chemoprotective effect. And I think what shifts this balance may be the lifestyle factors and the other factors in any particular patient on a case-by-case basis. I cannot overemphasize the role of the MDT in managing these patients. These are complex patients, and complex and difficult decisions have to be made with reliable colleagues. And as I say, all of these factors need to be taken into account when managing a patient such as this. And as I've said as well, that other than the IBD specific risk factors, one needs to identify as well as control for the other risk factors that we know are associated with cancer anyway. So I'm going to leave it here, and I'm going to ask Francis to share the last slide, which basically explains what we did. And then when he's done, I have asked one of the consultants in radiation oncology with whom we co-manage the patient to make a comment. I'll introduce her after Francis has done. Thank you. Francis, are you going to speak to the slide? I think you're muted.
Yeah, so can you hear me now?
Yes,
Yeah, just go to the slideshow at the top where it says from current slide.
the second tab.
Yeah, that's it.
If it does, there we go.
Yep, thanks so much. So for us, we had a multidisciplinary meeting regarding this patient, understanding the complexity behind this patient and all the comorbidities. And as you've heard it all about this patient. It was quite a complex case. So following the meeting, what we did was that having diagnosed her with the cancer on top of the IBD and the other comorbidities, we have to stop both the biologics and the immunomodulators for her. And then she's also due for radiotherapy on the 16th of October, 2021. She was seen in the clinic 2 weeks ago, and there was a marked worsening of her perianal disease. Bear in mind that we've already stopped our treatment. And therefore, we had to consult, again, our oncology colleagues and discuss extensively on the way forward. And this was what we all agreed, that we have to restart adalimumab again. Meanwhile, we have to delay methotrexate until she completes her radiotherapy treatment. So this was what we have to decide regarding her. And it's exactly case-by-case base that we have to take in this case, even though we know the fears with respect to the choice of treatment. But bearing in mind what we are seeing in the worsening of our disease condition, we have to make an informed decision that will help the patient and also give us a peace of mind. I think at this point, I also want to hand it over back to Prof. Mashiko again. Thank you so much.
Thank you, Francis. Once again, thanks for presenting that really interesting case. Jill, I don't know, do you want to take questions on the case first before we ask Dr. Pant to comment, or how do you want to play this?
No, I think let's ask Dr. Pant to comment, because we brought her here for her expertise, and we obviously want to make use of that while she's here.
All right, great, thank you. So we've asked Dr. Lydia Pant, who's from radiation oncology, who's a consultant with an expertise in breast cancer management, as I said, with whom we consulted on the co-management of this really difficult patient. And as Francis has said, the patient has actually relapsed in terms of her IBD. And I know there was a time they considered chemotherapy. So Dr. Pant, she's been in private practice, and she says she's quite happy to be back at UCT GSH joining the academics. Perhaps you can take us through on your perspective of the case. What were your considerations about what needed to be the next step? What were your concerns about us continuing the immunomodulator therapy and the biologics, and any other sort of comments that you might have that might be useful for this audience in case we encounter a similar situation. Over to you and welcome to our platform.
Thank you, Mashiko. And thank you, Innocent, for the presentation of the case. I must say I got involved about halfway through. So first Selani Tebe was also involved, and I just want to reiterate how important it is to do multidisciplinary meetings. I know the rule is in cancer, you can never treat a patient on your own because you always learn something, and there's valuable insights from all colleagues that thinks about different things. So that was important for us. And I think for us, it's also always important not just to treat the patient, but to look at the quality of life, because you can do all the textbook things and end up with a miserable patient, and then you have not done the right thing. So I think in the beginning, they were worried or wondering about the role of chemotherapy in the patient. And then what they did is they did axilla lymph node dissect, or just a biopsy, which showed that the lymph nodes was actually not involved. So that paved the way for upfront surgery, which is always a good thing in a case like this. So the patient went on to have a wide local excision and just a sentinel lymph node biopsy. And that was done on the 3rd of August. And when we actually got the histology back, then it's always also nice to look at the risk factors and then to try and predict with various scores that we have if the patient actually will benefit from adjuvant chemotherapy, because of course we wanted to first look at what are we supposed to do in this breast cancer patient, forgetting that she had Crohn's. But the good thing about it, it was a small tumor. It was only a 12 millimeter tumor. It was a grade 2. And also 1 out of the 3 nodes was positive. So that all worked out to give her an advantage of 2.3% over 10 years for chemotherapy. And usually we use 5% benefit really as indicative of patients needing chemotherapy. So we were comfortable about saying this patient does not need further chemotherapy. So that made it easier. The other thing is she was also strongly estrogen positive, so that gave us another treatment option. And because she's had a wide local excision, of course, we know that we need to do radiotherapy of the breast in order to get better tumor control locally. So if you look at the specifics of her histology, it actually shows that she's got positive margins for DCIS on the specimen. And she's just over 50 years. So again, we did bend the rules a little bit, and we're actually going to do a breast plus a boost of the tumor bed plus a supraclav, because she's got 1 out of 3 nodes positive with lymphovascular invasion and DCIS. So we know we're going to add benefit of doing supraclav rather than her coming back in a little while with a recurrence in that area. So we're going to do proper radiotherapy, and then we're going to give her the anti-hormonal treatment. I guess we're just going to follow her up, and I talked to Francia Malherbe again as well. We're going to almost follow her up as a high-risk patient. So it will be very important to do regular imaging on her to make sure that she has no recurrence in the breast locally as well. And then also, I am curious to see how she's going to do on the hormonal manipulation and what kind of side effects she's going to have with that. But we are going to start with the aromatase inhibitors because she's a postmenopausal lady. So that is what the data is showing, that she will have a better outcome if she can tolerate that. That's the other thing. Yeah, so again, just to come together as a team, and you can't always follow the data or the recommendations. You have to look at the patient in front of you and tailor-make your treatment to fit that specific case.
No, thanks for that. So it sounds to me like even if she didn't have Crohn's, you're giving her the same treatment that any other patient would have gotten, which is such an important point, because the data shows that because of the fears and the risks of recurrence, et cetera, these patients tend to have less therapy given to them for their breast cancer than a patient who doesn't have IBD with other sort of comorbid complications. So I think, her presentation, thankfully, allows her to get, the Rolls-Royce treatment irrespective. My second question is the radiotherapy. Is there any data to say what that might do to her IBD, if anything, or we don't know?
Remember, we are giving the radiotherapy quite above the diaphragm. So we know that radiotherapy side effects is local. So it depends on the area where you do your radiation, and that's where you get your side effects. So we have no worries about her IBD being flared up with radiotherapy to the breast.
Right.
Our other thing was just thinking about the dose of the methotrexate, because there is a little bit of data to show that methotrexate is a radiosensitizer. So that means while we're doing the radiotherapy and even afterwards, the patient can get a bit of an allergic reaction or skin rashes. But also that's only seen at high dosages of methotrexate. So that's also less of a concern in this patient.
Right. Jill, do you have any comments, or do you want us to go to the questions on the chat?
Yeah, just two comments. The first thing is that was the reason we stopped the methotrexate. So would you be happy, Dr. Van, for us to initiate it at a very low dose? We only give it to reduce the formation of antibodies to the monoclonal antibody.
Absolutely. I think you should restart that again. Yeah.
Great, thank you. And then the second thing is, sometimes we forget that our patients are also prepared to bear some risk. It's not just us. So when I saw in the clinic 2 weeks ago, from having an absolutely healed perineum, just stopping the Humira for a couple of months, this enormous cleft has started to open up, which is just one of the most dreadful complications of Crohn's. And she said, I don't care about the cancer. Give me the Humira. I will take any risk because I cannot live with that perianal Crohn's disease again.
Yeah,
absolutely.
So Masha, I think there was a couple of things on the chat.
Yeah. So
one thing. Do you want to take the questions?
I think Wisdom is referring to the data from South Africa. Look, there's no question that there are a whole lot of confounders for which we did not correct. It was purely a descriptive study, just to get a sense of what kinds of cancers and the rate of these cancers in this cohort. That data needs to be worked up, and we need to involve a control group, etc. So yes, indeed, plenty of confounders that have not been controlled for. Ope asks, hi Ope, I'm not sure where you're from. Nice to have you. He's asking, or she's asking, was the patient placed on anything for the hepatitis B? So I think her hepatitis B was positive, but the viral load was negative. So no, I think she would have to be assessed in terms of the inflammatory activity, the Hep E antigen positivity, etc. And then the liver team would have to decide whether she qualifies for therapy. From my recollection, with that viral load, she just needs to be monitored and not treated. Having said that, though, the fact that she's on immunosuppression therapy may reactivate the hepatitis B. So I think this is one loose end that we definitely need to tie up. Chris, do you have any comments about that?
Can I just comment on that?
Sure.
So there's pretty good recommendations that it's quite safe to use some anti-TNFs in somebody who's core antibody positive, as long as you keep a very close eye on the viral load and the liver functions.
Great, thanks, Jill.
Mashiko, excellent. I mean, really a complex, a clinical issue that we're often faced with. But it might just be worth pointing out that these are the biologics of the anti-TNF class.
Yes.
And the horizon is perhaps a little bit more reassuring, leading to, you know, the other biologics that are now available, perhaps not in state, but in private practice, the anti-integrins and the IL-12/23. So Jill, perhaps your approach might change when those are available.
Yeah, sure, absolutely. So certainly vedolizumab is very safe in cancer, and that would be an excellent choice. Ustekinumab also very little cancer signals coming from either of those classes of drugs.
Yeah. So I think that answers Mark. Yeah, and look, hopefully she goes back into some sort of steady state with the perianal disease, with us putting her back on the Humira. But I mean, in terms of her cancer risk, she sounds like she's a reasonable candidate to do well from that perspective. Clearly, she needs to stop smoking, and I think the issue of compliance with her needs to be managed quite seriously, because she's had sort of lapses. But you know, she's had a lot going on, which I think one can be compassionate about. Are there any other comments or any other colleagues that may have treated a patient in a similar situation? I saw some experienced gastroenterologists online. Well, it seems that we seem to have covered it, Jill. Do you have any sort of parting comments before I close?
Yeah, just something, and maybe Dr. Pan can also comment on this. So the immune checkpoint inhibitor, ipilimumab, is the treatment of choice for metastatic melanoma. And of course, the most dangerous side effect of that is a severe colitis, which resembles acute severe ulcerative colitis. And the treatment of choice there is infliximab. So I think maybe we were a little bit too hysterical about melanoma, but perhaps Dr. Pan would like to comment on that.
I must say, in practice, we don't see it as much. We, of course, keep an eye out for it. But I think, again, it's more important to manage the patient on a case-to-case basis and be aware of it, but it should not necessarily make you from not giving it. No.
Yeah, absolutely. So, Mash, I think we were out of time. Do you want to close, or do you want me to close?
I don't mind if you do. Thank you.
Okay. All right. So firstly, before we end off, I'd just like to thank Mashiko and Innocent for their excellent presentations. It was really an outstanding session. And also thanks very much to Dr. Pan for taking the time to join us and to share your expertise. It's really nice to have an MBT approach. I'd like to thank ECCO University of New Mexico, as well as the ECCO India team. Just to point out that feedback forms are available on the chat, and this is really important so we can know how we can improve these sessions. And the recordings, as Mashiko said, will be available on the GI website. I'd like to thank the GI Foundation, particularly Chris, of course, as well as Sharon and Karen for organizing these amazing meetings. I'd also like to thank our sponsors, Takeda, Asino, Amgen, Equity, Aspen, and Adcock Ingram, because we do really need their support. And just finally, to remind everybody that there is a GECCO meeting every week, and next week's meeting will be on hepatocellular carcinoma. So I hope you will join us then. So good afternoon, everybody, and I hope you have a good evening.
Thank you so much, Jill.
Bye.
Thank you, Dr. Pant. Really appreciate it.
Thank you. Pleasure.